My name is Vijay Daniels, and I am the Associate Program Director of Assessment for the Core Internal Medicine Residency Program at the University of Alberta. This is the first of a series of short YouTube videos aimed primarily at our frontline preceptors, but as well as our residents, in terms of explaining what competency-based medical education is and how things will change as we transition on July 1st. So the objectives of this talk are, by the end of this session, you'll be able to explain the main driver in moving to competency-based medical education, describe the current major players in a residency program, their viewpoint, and how this will change with CBME, discuss the changes to assessment of residents and the evaluation of frontline clinical preceptors as we transition, and finally, use an approach to make direct observation and feedback to residents as effective and time efficient as possible. Before I proceed, I just want to clarify the two terms competency-based medical education and competence by design. Competence by design, or CBD, is the Royal College branding of the CBME movement in Canada. Pure competency-based medical education is devoid of any requirements related to time, and instead residents can progress as quickly as slowly as needed with no regard for time. However, the Royal College realized that this is not realistic in our Canadian environment where residents are paid for service, as in many jurisdictions. And so their branding of competence by design is actually a hybrid model of pure CBME, but also honoring the constraints of time. For the sake of this talk, I'm just going to use the generic term, competency-based medical education, but we will continue to recognize that time is a factor that we cannot ignore. So, what is the main driver in moving to CBME? Well, this was a conversation I had with a resident sort of midway through their third year of residency. Has anyone observed you do a goal of care discussion? Nope. Why? Do you think somebody should? Well, how you conduct the conversation could determine whether the patient lives or dies during a critical moment. Don't you think at some point someone should have watched you do this just to make sure that you can do it well? Well, when you put it that way, I guess someone probably should. And this is something that can commonly happen. We implicitly entrust our residents to do certain skills that we've never observed them do and nobody's ever observed them do. That is definitely a problem. This is not something that needs some sort of research trial to prove. We would never ask a mechanic to do a research trial where you randomized one set of students to never be watched changing the brakes and just taking a theoretical test about it, and another arm to change the brakes. Same thing applies. It's about entrustment. Can I trust the learner to do, and then insert whatever key competency you want, be it a goals of care discussion, putting in a central line, or something a bit more abstract such as safely admit a sick patient in the emergency department with complex medical issues. And the real question is, how can I know I trust them to do whatever competency it is unless I watch them do it? And that's the crux of CBME. And this leads to the term entrustable professional activity, or EPAs for short. An EPA could be something like able to perform a goals of care discussion, or it could be, again, that abstract example of able to safely manage complex atypical presentations to the emergency department. So in our program, there are various numbers of EPAs depending on the stage of residency, and I'll come back to those stages a bit later. So the next objective is to describe the current major players in a residency program, their point of view, and how this will change with competency-based medical education. In addition, we'll also discuss the changes to the assessment of residents. These will be covered in the next two videos.